Pathology, we'd like to invite Dr. Wissam Ismail to give us a continuous medical education lecture about percutaneous nephrostomy. Professor Wissam. Biopsy. Okay.
Assalamu alaikum wa rahmatullah. I would like first to thank the conference organizers and the scientific committee for giving me a chance to talk today. Although the topic is not really helpful. The title of the talk is just the percutaneous renal biopsy. So I'll see what I can do about that. I'll start to say that really the renal biopsy was a major breakthrough when it was discovered by Merck in 1950. And through the 1950 and 1970 until now, it's really hard for the present day nephrologists and nephropathologists to conceive how renal pathology was understood before we knew the renal biopsy. The percutaneous renal biopsy and the simultaneous discovery of light microscopic technique, immunofluorescence, and electron microscopy have provided structural basis for the diagnosis of the many different variants of diseases we know today. So why the renal biopsy? Before I start with this, I would like to know how many of the audience are working in Cairo. Can I see a show of hands? Work in Cairo. Yes. Okay. So, why do we do a renal biopsy? The renal biopsy is not only for accurate diagnosis. It does play a critical role in the initial treatment of the patient, in the prognosis, and in the response, measuring the response to therapy. Without renal biopsies, we wouldn't have discovered these new diagnostic entities like IgG4 glomerulonephritis, C3 glomerulonephritis, and we wouldn't have known all diagnostic entities as analgesic nephropathies and CNI toxicity, for example. It is considered to be the most important tool in the management of patients with acute kidney injury and chronic kidney disease. However, we have very few patients with acute kidney injury who undergo biopsy. Actually, the clinical diagnosis of acute kidney injury is incorrect in at least 50% of cases. So another show of hands, how many of you would perform a renal biopsy for a patient who's presenting with an acute renal failure? Two? Just two? Okay. And it's even less with chronic kidney disease. Let's take diabetic patients, for example. Only 10% of diabetic patients are biopsied. Up to 2/3 do have a different diagnosis other than diabetic nephropathy. Again, if you have a patient who has been diabetic for 10 years, came presenting with a serum creat of 5.5, how many of you would biopsy? And the rest would consider that he is just moving into end stage. No consideration of any other acute insult on top of it. Okay, this is a study, it's a bit old study, but it shows you that this study was on 276 patients whom their management changed upon renal biopsy in 86% of nephrotic range proteinuria, 71% of acute renal failure, 45% of CKD, 32% of cases with proteinuria and hematuria, 12% on those with non-nephrotic proteinuria alone, and 3% in cases of hematuria alone. Overall, the clinical diagnosis was poor in around 45% of the cases. Until now, we still have very few non-invasive markers who can be specific enough to predict correctly the morphology that we can see. Let's take glomerulonephritis for an example. The classification of glomerulonephritis is actually quite a complicated classification, but we all know that this is a classification which depends on histopathology, clinical, etiology, and immune mechanisms. So if I followed your way, so clinically this is a rapidly progressive glomerulonephritis. What does rapidly progressive glomerulonephritis tell you about the actual disease the patient has? Is he vasculitic? Is he lupus, for example? It could be not glomerular at all. Etiology, it's a post-infectious glomerulonephritis. Yes, is it post-streptococcal? Is it post-IgA? Is it a chronic MPGN, which is superimposed, something else superimposed on it? Immune mechanisms, like lupus. So the patient is lupus. Which class of lupus is it? Do you know without the biopsy? So you still have this part which is missing, which is the histopathological classification, which is actually the classification glomerulonephritis is based on. Just few words about what do we do with the biopsy, or what we both do with the biopsy. The biopsy should be processed for light microscopy, immunofluorescence, and in ideal situations, which we don't have very frequent here in Egypt, for electron microscopy. It has to be fixed. All the 3 cores or the 2 cores or the single core you obtain has to be fixed. And they are not one fixative, unfortunately, till now. So for light microscopy, we use what we call 10% neutral buffered formalin. This is a very simple equation to buffer the formalin with just a simple phosphate buffer. Even table salt can be used. The whole idea is that concentrated formalin can burn the small core you have and can destroy the tissue. For immunofluorescence, if your center performs immunofluorescence, then this works on frozen section. So you need an unfixed specimen, which can be employed in an embedding material and snapped frozen. Or you can use a transport medium like Michel's transport medium. If instead in smaller centers or in private practice, immunoperoxidase is used in substitution for the immunofluorescence, then you don't need an unfixed specimen. The same core which is placed in the formalin will do. You do not need another core. For electron microscopy, these biopsies are fixed in 4% glutaraldehyde, which is also available in most of labs. But please remember that saline is not a fixative. Saline is something which is just used to prevent drying. When you send a core in saline somewhere distant to another lab, you lose the tissue because simply the tissue gets autolyzed. So the only circumstance, exceptional circumstances you can use saline in, if the lab is on the 1st floor, you're performing the biopsy in the 6th floor, it might take few minutes to go down with the biopsy, then you can just put some saline to prevent the dryness of the core. Otherwise, this is not a fixative, we don't need it, we do not use it. If you're performing immunofluorescence, then again, this is going to be in the same hospital or the center you're working in, because you don't go around with fresh tissue. If you're sending the biopsy for any reason out, then please fix it. Otherwise, you will lose the core. We don't need to freeze the biopsies. And we use just a regular fridge, not a freezer, for those who are going to go EM, for the glutaraldehyde fixed ones, if you're going to leave it overnight before you give it to the lab. Otherwise, do not put the biopsy, especially the formalin fixed biopsies, in the fridge. It causes processing artifacts and actually compromise the quality of the specimen. Please label the vials. If you're sending one for light microscopy, for electron microscopy, and even if you have a separate core which you want to consider for IP, please label them. It's not always feasible to know which is which. Maybe the technician in the lab is going to be the one who is going to receive it, and glutaraldehyde fixed specimens are not suitable to be processed for light microscopy, nor vice versa. So a simple thing, just label the vials. And remember that it's very important that the same pathologist interprets the results obtained by the 3 techniques. If you want to obtain a second opinion, just send all the data again to the second pathologist. But make sure that it's the same pathologist who reads your light microscopy, the immuno, and the EM if available. Just to give you an idea on the stains we use, which are very important for renal biopsy, this is an H&E stain. This is a glomerulus, more or less normal. This is the basement membrane. These nuclei are the endothelial cells. This very little pink material, which I'm going to show to you, is the mesangium. These are the tubules, and normally you shouldn't see any interstitium. This is the silver stain, and this is a stain which is used from basement membranes. It stains basement membranes black, and again, these are the capillary loops here. It also stains the mesangium black, as you can see, Bowman's capsule black, tubular basement membranes black, and these are the peritubular capillaries in between tubules. An alternative to the silver will be the PAS, or periodic acid shift stain. This time it also stains the basement membrane and the mesangium, but instead of black, it stains it this reddish pink color. Again, capillary loops, mesangium, and tubules. And this is what we call the fibrosis, or the fibrous tissue stains, the trichrome stains, and it gives this green color if there is fibrosis. Again, a tubule, and this is fibrous. This is expansion of the interstitium by fibrous tissue, and you have here some infiltrate. For the immunostudies, you can use either immunofluorescence, like what you see here on the left panel, or immunoperoxidase on the right panel. Antibodies used are IgA, IgG, IgM, complement factors like C3, C4, C1q, fibrinogen, and kappa and lambda. At least the basic panel, which is the first 4 antibodies, needs to be available for diagnosis. If you can't afford to do the 7, at least have the first 4. As I've just mentioned, immunofluorescence is used for frozen sections. It needs a special microscope, and it needs a dark room, and it has its own internal controls. However, peroxidase works on the formalin-fixed sections. Any standard microscope in any lab you can scope the specimen with it. EM, just to show you an example, this is the EM photos. They also always come black and white. You can see this is a basement membrane. These are subepithelial deposits. Again, here a basement membrane. This is the endothelium side, and all of these black lumps are what we call electron-dense deposits, and they are subendothelial or on the endothelial side of the capillary basement membrane. So we have the biopsy, we fix the biopsy, we work the biopsy with the special stains. How do we interpret the biopsy? The interpretation is actually something which needs both the pathologist and the nephrologist. It is the responsibility of the pathologist to produce an accurate morphological diagnosis as much as possible. However, it is the responsibility of the nephrologist to provide an adequate biopsy and complete comprehensive data. What's an adequate biopsy? First thing is that whether this is cortex or medulla. And if we need cortex, since usually the most suspected glomerular disease are glomerular diseases, please do not use a needle size which is less than 16 gauge. 18 gauge ones are really useless. They produce very thin cores, collapsed glomeruli, and are very difficult to interpret. An adequate biopsy will be in a native kidney, a minimum of 8. Less than that, it's very difficult to exclude certain diseases, preferably 10 glomeruli. And in transplant kidney, we need a more generous biopsy, 10 glomeruli and 2 arteries. Why do we need this adequacy? Because we have the problem of focal diseases versus diffuse lesions. And the fact remains that always the smaller the biopsy, the more you need to know, although the biopsy is really very small. If you have a 10% chance of a focal lesion and you have 10 glomeruli, which is an adequate biopsy, you still have a 35% chance of missing it. And if the focal lesion is 25% and the number of glomeruli is still 10, then you still have a 5% chance of missing it. In diffuse lesions like membranous glomerulopathy, lupus nephritis, for example, still an inadequate biopsy will prevent you from knowing the activity, the chronicity of the process, whether you have secondary segmental sclerosis, do you have crescents or necrosis, what about the interstitial fibrosis, and this is why we add the number of glomeruli in the report, to let you know how adequate the clinical our diagnosis is in relation to the size of the biopsy. As I said, interpretation is a conjoint effort of a clinician and a pathologist, as the first classification of renal disease in 1914 ever was between Volhard, who was a nephrologist, and Theodore Farr, who was a pathologist. And in order to do this, we need clinical data. Renal biopsy from a patient with proteinuria is not clinical data. Rising serum creat means absolutely nothing. Hypertension is not a useful sentence, as impaired renal function. Nephrotic syndrome, we need to know the range of the proteinuria, we need to know numbers. Query lupus nephritis. Lupus nephritis is not a pathological diagnosis, it's a clinical diagnosis. So you should tell me whether the patient is nephrotic